Well, welcome to tonight's webinar. Unfortunately, my friend and colleague Peter de Jong is out of action, so he's not able to join us, but it is indeed wonderful to have all of you joining us tonight. And tonight, we've got a slightly slimmed down version of the webinars, obviously without Pete. And we do have a video that's by Trudy Smith, who's a wonderful speaker. But again, sadly, she's unable to join us as well for the actual webinar in person. So we have really the video. We've got the video, and you'll have me hosting. But we'll be happy to take some questions. But bearing in mind that true menopause experts are not actually on the call, so we'll be doing that through a slightly different method. And if we have some questions, I might bounce it out to everybody who's on tonight, and you can maybe give us some answers as well, and we can do that as a team. So but it truly indeed lovely to have all of you. It's a great privilege as well to have Bayer sponsoring us, and thanks for the generous support for tonight's meeting. And we have Zelda, we have Emily with us tonight, and we are very happy to have them with us as well. So be very happy to have their comments as well as we go through the webinar. So we'll first be playing the video. You can pop your questions onto the chat during the webinar so we can start thinking about the answers, but we'll only be able to have those discussions at the end. So but Trudy Smith is a wonderful speaker. She's an expert on menopause, contraception. She's been a lecturer and a teacher at WITS for years. She's currently in private practice, also a very good gynecologist. So yeah, we can fire away, Chris, and we'll take the questions at the end, and we can have some further helpful discussion a little bit later. Thanks very much, Chris.
Have you got it?
Yes, thank you.
So I should have entitled it Choosing the Right Hormone Treatment for Myself as a menopausal woman, and having transitioned into my postmenopausal phase. I can tell you it's not an easy time for women. So I have lots of disclaimers, but let's get to it. So menopause, basically the word menopause, so often, am I in menopause, doctor? And the word menopause just means the last menstrual period that you've ever had, which obviously is easy when you've got an intact uterus. But it's due to the cyclical loss of estradiol, progesterone, and testosterone. And let's not forget, women who have a Mirena and don't have periods won't know when their last menstrual period was, or in fact, women who have had a hysterectomy and still have their ovaries intact will not be able to know when their last menstrual period is, but they certainly may develop symptoms. So the average age of menopause is around about 51.5, but 1 in 10 women, which I think is quite high, will reach the menopause before the age of 45. But we need to also distinguish the difference between early menopause and premature ovarian insufficiency. So early menopause is when you have your last menstrual period between the ages of 40 and 45, whereas premature ovarian insufficiency happens in women before the age of 40. So there's often family lines, and I have, for instance, a group of women who are sisters, and they became menopausal at the age of 39. And in fact, so did their mother. And if you speak to those women and they have girl children, obviously they need to tell their daughters that, should they require fertility, they need to, women are having children later and later. And if you're having family lines of an early menopause, then you have to be wary of those young women who may lose their reproductive capabilities early. So there certainly are ethnic differences. And what's quite interesting, I find, is that even there's differences in terms of developing countries and developed countries. And also there are differences in terms of whether you live at sea level or you live above sea level. So for instance, in Johannesburg, our menopause might be a bit earlier than people, slightly earlier than women who live at sea level. So, you know, it would be interesting to have a look, you know, if you go to Machu Picchu, the women who live up there, when their last menstrual period was. But there certainly are ethnic differences, and there are differences.
Trudy?
Yeah.
So why would you, how do you explain that, the fact that people in Cape Town have a later menopause?
Do you think it's because we're oxygen deprived in Johannesburg? I'm not sure. I don't think we can explain it.
But also women that smoke, you mentioned smoking, they also have earlier menopause, which is also oxygen deprivation.
Exactly. So, you know, there must be something linked to it. That's what my thoughts were, but I don't think we truly know why, you know. Okay. And I think what is interesting, I don't know if your incidents in Cape Town, but in Johannesburg, vaping is a huge, massive problem for us. And lots of women vape as opposed to smoking, believing that it's much better for them. And in fact, from a cervical cancer perspective and, you know, from many other things, we're starting to see that, in fact, the diseases are pretty similar. So vaping doesn't necessarily mean that you're not going to get smoking-induced diseases.
Right.
But I think what is, if you look at this work that was done by Nicole Jaff, she really has done most of the work in our Black urban population. We have very little data, in fact, in our Black women in South Africa, and I would really urge people to start, our registrars, etc. We really need to start looking at it. But what she found in her PhD work, in fact, that she did, is that women, their final menstrual period was round about 46, but there was a wide range. And she believed that the further you were away from your last menstrual period, the less likely you to remember exactly when it was. So we're not sure whether this data is accurate or not. But I think what is more important is if we're going to do any form of meaningful studies or you know, we're going to write about it, we should really use the straw classification. And it looks super complex, but it's actually not that complex. So it has 10 stages to it. And this is a table which illustrates that you basically go from your reproductive to your menopausal transition to your post-menopause, and that your menopausal transition can either be early or late, and that your FSH varies. So, you know, to say to a woman, you are menopausal because your FSH is high, they might in fact only be in their early menopausal transition. And while their fertility is lower than a reproductive woman, it nevertheless, contraception and fertility needs to be discussed in these women. So just because you have a high FSH does not mean that you are post-menopausal. You might still be in your early transition. So one moment in time is not enough in order to say that somebody is menopausal. So if you've got somebody with a Mirena, for instance, who's having some symptoms and you measure their FSH today, it might be different in 6 weeks' time. So you need to, you know, think about doing it at least 6 weeks apart so that perhaps they're in a different part of their cycle. And that makes it when you want to stop contraception. So if somebody's on an oral contraceptive, you know, classically we teach that you should stop at 51 years of age. And then you measure the FSH 10 days later. And then if it looks menopausal, you must repeat it because it may not be menopausal. And you need to counsel a person to use alternative forms of contraception in that time. So the symptoms are huge and varied, and there are up to 34 or even more symptoms of menopause. So, you know, we only often think that it's a hot flush, that a menopausal woman might have. But in fact, so many things. Sensation under the skin is in fact quite a common one, as is a change in a woman's body odor. They feel as if their whole body smells are different. Perhaps I don't know in your practice, but in my practice, weight gain, brain fog, and fatigue seem to be the biggest complaints from women who have transitioned into their postmenopausal life, as well as joint pain. But the problem is a lot of these are non-specific, and apart from hot flushes, they can be accounted to many other things, arthritis, for instance, etc. Mood disorders are much more common. Anxiety, particularly anxiety. If you, there's excellent work now on women in the workplace who are transitioning into the menopause. If you look at CFOs and CEOs of companies, there are very few who get promotion between the ages of 47 and 52. Have you ever noticed that? And there's data on that.
No, I haven't noticed that yet.
Yeah, and there's data on that. And that is because a lot of women in this time kind of lose their balls, for want of a better word. They lose their, you know, they become anxious, etc. So I think to just say the commonest ones are vasomotor, but certainly they can be varied, and to sit and listen is important. So the symptoms, however, can start several years before the last menstrual period, and in fact can be 2 to 9 years. So there's no cutoff of age when the symptoms begin or when they end. You know, a woman will say, when will my hot flushes stop? Well, 25% of women continue to flush until they die. So not everybody's hot flushes stop. So each person is an individual, and each person will experience different symptoms. Some women cruise through it with no symptoms, actually, but, you know, it's very, very varied.
Trudy?
Yes.
This is a very interesting question. Why do some women not have any symptoms at all, and other people flush until they die? Is there any explanation?
So it's this change. So the difference between asymptomatic and symptomatic women seems to be in their thermoneutral zone. So generally, you know, when you're not menopausal, you don't feel a slight change in temperature. But in some women, their thermoneutral zone is very small compared to others. And we don't know exactly why some women flush more than others. But again, it's often hereditary. You know, you speak, did your mom have symptoms? Yes, she did. So I think those are also important questions. And we're starting to learn about these neurokinin B receptors, and they are upregulated in estrogen deficiency. And it's quite complex. It's to do with candy neurons. And that, in fact, is probably going to be the new treatment, is centrally acting inhibitors of neurokinin B, as opposed to hormone replacement therapy for those women who are flushing. So different responses to warming. You know, you get those women that are like wearing sweatbands, and those other women who say, oh my God, I'm having a hot flush, and you see nothing. So I think it's very subjective, but if you're doing research, there are in fact monitors that they put on that measure a small change in temperature and measure a hot flush, because it might be underreported even though the person's having a flush. So if you look overall, how do you treat symptomatic women? And there's a lot of controversy over it. But the bottom line is that you can try all the other stuff. You know, if you go to a chemist and there's 27 shelves of medication for a symptom, it usually means everybody's trying everything. And there's a large placebo effect. But the bottom line is estrogen. Estrogen is the only thing that helps from a symptomatic perspective in terms of hot flushes. So it's really about individualizing your risk-benefit ratio. So we know that estrogen is good on your bones. We know that estrogen, when instituted early, prevents coronary vascular disease. We know that estrogen is probably good on your bones, on your brain, but there are risks, obviously. That's the venous thrombosis, the stroke. The breast cancer risk is only in estrogen and progesterone. Estrogen itself, in fact, in women who have had a hysterectomy, have a decreased risk of breast cancer. It is the combination that is the problem, not the estrogen alone. And estrogen got a bad rap because of that. But we're living longer, we're getting older. It's a big problem because, first of all, we don't have enough money to live until we're older. And, you know, university rules say we have to retire at 63. And if we're living to 100, it's a bit of a problem. Government says we must retire at 65, and yet we are becoming older and older. So if you look at the international statistics.
On that point, I think it's a very interesting discussion, which I think we need to, bring up here, is that, I think age is really starting to be completely redefined. I mean, I'm seeing 70-year-olds who are still working,
like me,
completely economically active. And, I think it's the whole retirement thing's going to have to be completely redefined. So it is a bit of a ridiculous, and this is such an important conversation. Aging is completely new world out there.
And I think aging is an individual thing, because you can have an old 50-year-old and a young 80-year-old, if you understand what I'm saying. It's incredibly individual. But if you look at a woman, an aged woman, or a woman over the age of 80, the majority of women don't die of breast cancer. They die of osteoporotic fractures and coronary vascular disease. So
at that last menopausal meeting, you were there, Trudy, 50% of women over the age of the menopause die of cardiovascular and not cancer and not osteoporosis. And so it's all about your heart when you're over the menopause.
Absolutely. It's about lifestyle, isn't it? It's about lifestyle and maintaining a good heart health overall. I mean, our cells age whether we like it or not, but it's whether our brain ages and what we do with our bodies that is important. If you look at these statistics, you'll see that in North America, Europe, and in Australia, the average age of demise is 80. I mean, in South Africa, or in Africa, we're still at 64. But yes, the world is getting older, and it does need to be redefined. So this is where the timing hypothesis comes in terms of prevention of heart disease. If you look at the gerontology articles, you'll see that women who take hormone replacement therapy within 10 years of their last menstrual period, from a cardiovascular risk, they are much better off than women who take HRT much later. So your overall mortality, your risk of dying is less if you start your hormone treatment early. And that's why in the Menopause Society, we have a cutoff of 60. We say, if you haven't taken HRT before the age of 60, then you must not put somebody who's over 60 onto HRT who's never been on HRT before. But that's why there's this window of opportunity. But say, for instance, you have a patient, I don't know why that 5-year story came in and everybody started stopping HRT after 5 years. Oh, you must get off the stuff after 5 years, because it was felt that that's when your breast cancer risk increased. And now these women are flushing. 2 years later, they come to you and they say, I can't do this anymore. Put me back on my HRT. And I'm comfortable with them going back on HRT at that stage. We probably should never have taken them off their HT in any case. So you can say to a patient, if they say, I want to come off my hormone treatment, we say, well, we'll taper it down, see how you do. But if you're flushing, you're not feeling great, just go back on and stay on it. So there's no more time limit to how long you can use it, but there is a time initiation that there is. So it needs to be before the age of 60 if you're going to use it.
And on that score, are you going to talk about when to stop or not?
I'm saying there is no time to stop. You can
carry on to the dying day.
You can carry on to your dying day. So most of the European societies and the American societies say that from the age of 60 or after 10 years, you can taper it down and see how you cope. And if your symptoms return, then you just stay on it. So there's no more time limit on how long you can stay on it. But the one thing we have to speak about is clotting. What about clotting? So the incidence of thromboembolic disease increases the older you get. But if you institute hormone replacement treatment early on, you'll see that the incidence, in fact, is very low. But it's also related to weight. So the more obese you are, the higher your risk of having a thrombotic event. But that's why in women who are at risk of thrombotic events, you should be using a transdermal as opposed to an oral. Because if you look at the progestogens, do they make a difference? If you look at the difference between an oral progestogen compared to a transdermal progestogen, the risk of clotting is less. But should you use an oral progestogen, you should be using a micronized progesterone. So something like utrogestin, for instance, because that risk of clotting is also decreased, but as opposed to the progestogen. So the norpregnans and the northistrone and all of those other progestogens have a higher risk. So for instance, the patches, Istralis, Everil Conti, Everil Sequi, they have a progestogen, but it's transdermal, and therefore the clotting risk, the combination of the estrogen and the progesterone is less. And if we look at the estrogens, I'll show you, the estrogens transdermal is far less. But we need to also consider tibolone in the mix, because tibolone is not a progestogen and it's not an estrogen either. It's a plant extract, and it's broken down into 3 isomers that act on estrogen receptors, progesterone receptors, and testosterone receptors. So it's the only hormone treatment that actually acts on testosterone receptors, or the only registered hormone treatment that acts on libido. So it's slightly different to other hormone treatments. But if you look at the tibolone risk for clotting overall, in fact, it's relatively neutral. It does not increase your clotting risk. So if you wanted to use an oral hormone treatment in somebody with a uterus, tibolone might be a better one from a clotting risk compared to using, for instance, the others that contain other progestogens in them. But if you look at now a different progestogen, now we're going to use, am I confusing you? No.
No.
So the other progestogen, obviously, that you can use is a Mirena. What I want to stress here is you cannot use a Kylina. There's no data on Kylina. Many people want to use the Kylina because it's smaller and perhaps they say easier to introduce. But if you look at it from a uterine protection in postmenopausal women, we don't have data on Kylina. We need to use a Mirena because a Mirena contains a higher dose of levonorgestrel and gives you better estrogen, better endometrial protection compared to the other smaller Kylina loop. And in fact, it seems to be neutral from a clotting thrombotic perspective. So it possibly is a good option to use a Mirena with somebody with a clotting propensity plus a transdermal estrogen in the form of a gel, femigel, or a patch.
There's a question Sorry, there's
Yeah.
a question here. If a woman's had a previous pulmonary embolism and they desperate to use hormonal therapy, can you add Xalatan to the mix? In other words, an oral
Xarelto.
I mean, not Xalatan, Xarelto.
Xarelto. So
Xalatan is stuff you use in your eyes for glaucoma. Xalatan and Xarelto is the anti.
yeah, so Xarelto. So I think that the other generic one is called Equalis or something like that. So you don't have to add Xarelto. So somebody who's had it depends how recent the pulmonary embolus is. If they've had a pulmonary embolus a long time ago, you can use a transdermal hormone treatment in those women. It depends, why did they have the pulmonary embolus? If they had the pulmonary embolus with an underlying clotting disorder, like a protein S or a protein C or a factor V laden, I may consider a low dose of Xarelto, but I would certainly consult with my friendly hematologist like Professor Jacobson, who would tell me to use a Xarelto 10 milligrams, not 20.
No, he definitely say that. He definitely will say that.
He definitely will say that. But what I have to stipulate is, I don't know if I'm seeing like a lot of practitioners in our area, they give continuous estrogen and then they're giving a progestogen once a week or twice a week. And there is absolutely no data for that. So in fact, if you look at the data of progestogens, your risk of endometrial carcinoma is the least if you use continuous combined. If you use sequential and you continue to use sequential, your risk of endometrial carcinoma goes up. So if there is a uterus, you should be using continuous combined in women, particularly if they're at least a year after their last menstrual period. And the minimum dose that you should be using is either 100 milligrams of micronized progesterone or utrogestin. You can use 0.5 of drospirenone, that's what is in Angelique. You can use 0.1 milligrams of the norethindrone or 1.5 of medroxyprogesterone. We're trying to stay away from medroxyprogesterone because the WHI data was medroxyprogesterone plus conjugated equine estrogen. The other thing is, if you need to use it sequentially, so you've got somebody who's in an early menopause and still bleeding and bleeding irregularly, you must use at least 10 days of continuous progesterone. You can't use it twice a week or 3 times a week. You need to use it continuously for 10 days. So you get that endometrial shedding in a sequential hormone treatment. The one other thing that I have to stipulate is progesterone creams. This is a smear cream that is being issued, is not well absorbed. There is no efficacy data. And in fact, last week I did an endometrial carcinoma patient on somebody who was given bioidentical hormone treatment with progesterone cream. So I've highlighted, underline, circle, tell you progesterone cream must not be used. It has no efficacy on hot flushes. We have no data on VTEs, and we certainly are seeing an increase in endometrial carcinomas. So the only transdermal progestogen is in a patch form that we have. There is no other transdermal progesterone cream that works.
Sorry, Trudy.
Yes.
What is the difference then between the transdermal patch progesterone and a progesterone cream? Is it merely the way it's made?
It's the way it's made, and the transdermal is a progestogen. It's not a progesterone.
Okay.
So it's not a natural progesterone. It is a potent progestogen that is absorbed transdermally in the patch. And that's why we don't have a cream, a registered cream to date of progesterone, because of the poor absorption.
Okay.
So what is quite, I don't know, but I got a thing from a patient who said she's been offered bioidentical hormones from the NHS in the United Kingdom. So I went, send me a picture. So the bioidentical, the marketing of bioidentical in the United Kingdom is Femigel, which is estradiol, yeah, plus Utrogestin orally, which is progesterone. So, you know, there is conventional bioidentical hormone treatment that is registered, licensed. We know its effects. But I found that quite interesting that now the UK is using that word in conventional hormone treatment.
It's a great selling point, a great marketing point, because we have many women here. If you say bioidentical or natural or that other word that they use, it's a great selling point. And I think, it must be better than the usual stuff.
But is estradiol vaguely bioidentical? Isn't that a synthetic hormone, or is it?
Estradiol. Everything I tell patients. Estradiol. So Femigel is estradiol. It's bioidentical. But I tell patients, what does the word bioidentical mean? I don't take it from another human and give it to another human. It's all made in a factory, you know, it's like Klomkak, you know, it's all made in a factory. So if you look basically at oral versus transdermal hormone treatment, there's no doubt that transdermal is trumps from a clotting perspective. So we really should be considering transdermal when we script hormone treatment. So if we look at...
That's a good place to start, is it then Femigel plus Utrogestin? That's a starting point, as in orals. Are you saying that to us?
Yeah, but you know, it's different for different patients. So for instance, I tried a transdermal, but a transdermal hormone treatment can give you incredible breast tenderness, for instance. And some people don't like transdermal hormone treatment, and they want to take a tablet every day with their other tablets. It's much easier than pumping and smearing. Do you understand? Or remembering to change your patch on twice a week. So it's very individualized. It really needs to be very individualized. For instance, if we've got a patient who complains of acne and hair loss, you should consider something with drospirenone as your progestogen, so your anti-androgenic progestogen. So you would consider something like Angelique. Angelique is much better on hair and acne. So if you've got adult onset acne in the menopause, that would be your drug of choice, as opposed to using anything else. So it's individualizing your treatment. That's important. So when we compare the estrogens, there's no doubt transdermal estrogen from a deep vein thrombosis perspective is far less compared to the oral. So, I mean, again, continuing on the theme. But what about hereditary thrombotic conditions? So in factor V laden and the G2021A prothrombin gene mutation, there's a significant increase in thrombotic events if you use a hormone replacement therapy. And in real terms, it's a very small risk. So you have to only use it in somebody who is really symptomatic and you are unable to control their symptoms any other way. I mean, I had a patient that we had to do a TAH BSO for an ovarian carcinoma who had factor V laden. And she went Meshuggah afterwards, and we couldn't control her on anything else. So we had to use a hormone replacement therapy. And in that particular patient, I used a transdermal with Xarelto.
Could you just clarify the term Meshuggah?
So Meshuggah means she went literally. She was so depressed. She was flushing. She couldn't sleep. She really lost the plot.
Mad.
She did.
Okay.
She did.
So sorry, I interrupted you. You were saying that you used Xarelto with that particular case.
With that particular patient. So if you really have to use it and you've weighed your risks and your benefits, then you must stick to a transdermal. You cannot use an oral in that patient. Another group of patients that you have to be wary of are those patients with lupus and antiphospholipid syndrome. So there are 3 randomized trials on those patients, and those patients, HRT does not seem to increase the flares of their disease, but certainly there's a small thrombotic risk. And you need to avoid it, particularly in those patients with antiphospholipid antibodies, because they are at tremendous risk of thrombotic events. And again, risk benefit, and if you're going to do it, transdermal, if you need to use a hormone treatment in these patients.
Trudy?
Yes.
Sorry, we're falling a bit behind with the questions over here. Katja Jagot asks, with regard to the time limit of hormonal therapy, does the risk of breast cancer not increase with prolonged use? In other words, if you use it to the woman's dying day, is she not at higher risk of breast cancer? Yes or no?
The answer is yes, she is at slight higher increased risk of breast cancer. But now do you say to a woman after 5 years, you have to stop? You're at slightly increased risk of breast cancer. Off you go and flush and have a terrible life. You know, it's about risk-benefit ratio. And the risk of breast cancer, in fact, is not huge. It is not huge. I think that,
so that answers nicely, yeah.
Yeah,
so
I mean, it's relative. I mean, if you look at the statistics, 5 in 100 women who were not on HRT developed breast cancer, 8 in 100 developed breast cancer who were on HRT. It actually was not statistically significant, but yes, it was increased, you know? So what are the recommendations? So the recommendations is that you should probably not use it in somebody who's had a pulmonary embolus or an unprovoked clot, and that somebody who's had a traumatic clot, you can use it, preferably a transdermal. If somebody's got a family history, you don't always have to do lab work, but it depends how strong the family history is. But, you know, most of those women would have been on oral contraceptives in any case. So then, you know, they probably would be okay. And the history of migraines is quite interesting. Transdermal preparations can be used in women with migraines, as opposed to, for instance, oral contraceptives where it shouldn't be used. We might not be able to get through everything, but we can do a few more things. What about hypertension and diabetes?
We better just have a little bit of time at the end for 1 or 2 questions. People are stacking their questions here. Thanks, Trudy.
So hypertension and diabetes. Well, diabetes is decreased in women who use hormone replacement therapy, and particularly women who use transdermal hormone replacement therapy. Their diabetic management was better. But if you look at the American Endocrine Society, they say HRT is not recommended for the prevention of diabetes. But in women with previously diagnosed diabetes, HRT, if they use it, in fact, decreases their diabetic control is much better and improves their cardiovascular risk. So there are benefits to the use of hormone treatment in diabetic women who are symptomatic. We've spoken about this, the timing hypothesis, so we don't have to go through this again, but again, use it within the first 10 years of becoming menopausal. You need to start hormone treatment. So if you look at this table, so it summarizes, if you are hypertensive and you're well controlled, use an oral or a transdermal. If you're uncontrolled, transdermal or non-hormonal options should be used. So again, sticking to the theme, look across there, transdermal, transdermal, transdermal. That's what it's saying in most of them. In obese patients, diabetic patients, patients with dyslipidemia, you should be using the transdermal. In obese patients who, it's not a contraindication to using hormone treatment in obese patients who are flushing. Use a transdermal. What about tibolone? So tibolone, we'll just say about tibolone is that tibolone, basically, if you look in the randomized control trials, is neutral on blood pressure. So you can use tibolone in patients with well-controlled diabetes as well. So brain fog. Brain fog's a big complaint from patients. And this white paper should be read by all of us. It's a fantastic paper. It's written in a way that is simple for all of us to understand. And I would really recommend everybody gets this paper and reads this paper. The bottom line is, if you're looking for optimal brain health, if you want to stay clever in your aging years, is that you should not smoke. I mean, these are all common sense. You must stay connected. So social engagements are very important. You should be doing some form of brain exercise. So you learn a language, learn a new instrument, etc. You need to make sure you're not overweight. Look after your heart. It's all about your heart, and exercise. These are all common sense things that actually, from a brain health perspective, are very important. But the data on cognition, does it help your brain fog? It doesn't help everybody's brain fog, but we know that if it's introduced soon after the menopause, it possibly decreases the risk of dementia. But here's a little difference between the transdermal and the oral. The oral seems to improve mood better than transdermal. Isn't that interesting? So an oral estrogen combined with a micronized progesterone has a lower depression rate, because you know the progestogens are actually depressants compared to progesterone. So that's why, like for instance, a Mirena, if you use a Mirena in somebody with a major depressive disorder, it actually can make their depression worse, the levonorgestrel within the Mirena. So you have the progestogens are not so good from a depression perspective, but the progesterone is better, because progesterone acts on GABA receptors and helps sleep. So when you prescribe it, patients must take it at night. It improves their sleep. Tibolone, is it neuroprotective? So there is some good data to say that, in fact, tibolone has a rapid effect on GABAergic and melatonin receptors, and it improves depression. And tibolone decreases sex hormone binding globulin, therefore increases your testosterone. That's why it's good on libido. And that's why it also has an improvement on cognition and mood. So tibolone's a good drug for patients who have anxiety and depression and libido issues. So you see how the nuances, they all differ according to what's wrong with your patient, what their needs are. Sexual health, a quick word on sexual health. Well, sexual health, the only registered drug from a sexual health perspective is oral hormone or transdermal hormone treatment doesn't improve your vagina. I mean, you both know from a pelvic floor society, or from a pelvic floor perspective, you need to use extra intravaginal estrogen in postmenopausal women. So by putting them on a transdermal or an oral, it doesn't help their vagina. But in fact, tibolone does improve your vaginal maturation index and improves lubrication. So it's the only oral drug that will improve vaginal lubrication compared to the other two drugs. And it's the only drug that we have available that will improve libido. And then I think we'll keep it here. Yeah?
Just before, yeah, you know, tibolone's wonderful, and there are now 2 generics available.
Yes, but, much cheaper.
Much cheaper. But we at that recent menopausal congress, we heard that you should actually use vaginal estrogens for sexual reasons. But tibolone's wonderful stuff, but it doesn't always work on everybody. I mean, I've got some patients who got tibolone, And I said, does your libido better? And they say, it's no different. So it's not magic. And I guess, as you said, everybody is different and you have to individualize.
Well, also libido is very, it's a complex subject, and it's a whole subject on its own. You know, as females, we have many buttons to press and many things to fix. It's not, there's no a pill. We can't, it's not like erectile dysfunction. You know, if I look at your skiff and give you a Viagra, it's going to happen. Do you understand? It's not necessarily going to happen from a female perspective. There's lots of nuances, lots of problems. Sexual health is a very different topic on its own. And then just I'm going to start with here because I see we've got min time and then we've got time for questions, is that we did the study on vaginal atrophy. It is the most underspoken about, undertreated condition in postmenopausal women. We need to ask the question, is your vagina dry? Are you having overactive bladder symptoms? Is sex uncomfortable? And if it is, we must be liberally giving vaginal estrogen. Liberally. You can use tamoxifen, you can use Vagifem in women on tamoxifen and ask the question of those women on tamoxifen. You know, do you have vaginal? Those women get recurrent bladder infections, vaginal atrophy, sex is uncomfortable, give them Vagifem. Our oncologists allow us to give Vagifem.
Yeah, ours too. I mean, it's a shame that it isn't more widely used, and we have made this punt before, but I'm not sure why it hasn't caught on. Steve, do you have any ideas? I mean, you did a study on vaginal estrogen, Menopause.
But I mean, I absolutely agree with Trudy. I mean, it does amaze me how you'll see patients coming with quite advanced and recurrent UTIs and all sorts of symptoms, and no one has actually thought of a simple thing like a vaginal estrogen tablet or cream. And I think that's probably the biggest take home of the day for me, is that just always remember it. I mean, the gynaes out there aren't giving it.
Why is that? Why don't they use it? Is there any reason?
Maybe they forget, or maybe we just...
and it's over the counter. It's over the counter. It's an OTC Schedule 2 drug.
No. Is that Premarin as well as Vagifem? I know
Vagifem and Menopause.
Look, I mean, I think that over the last 2 years, none of the companies have made it easy for us. You know, Premarin was off the market for a long time. Menopause, who knows, comes and goes. I mean, it's a wonderful treatment, but it's not available in most places. And we are left with Vagifem, but it's a tablet. And I do think that a lot of patients still do very well with the creams. And I think, you know, it does make sense to give the cream to a lot of patients. So nice to have Premarin back. But yeah, who knows? But thanks. I mean, I think.
But it's also a discussion. I don't know, you know, I think it's something as well we need to teach our registrars. We need to talk about sex in the vagina. You know, it's like, ooh, we don't talk about it. You need to ask them. If you don't ask, you won't find out.
I mean, I think even the menopause doesn't get, I mean, a lot of attention. You know, people are doing, you know, other things, but I suppose it is something that needs a lot of attention in the undergraduate and postgraduate level. But maybe that's not the right thing for our discussion. Should we look at the other question, please?
Steve, ask the next one, anonymous.
I have a 57-year-old postmenopausal woman with chronic hypertension, previous stroke with a complete recovery, and previous smoker. She complains of vasomotor symptoms, and she's on Depo-Provera for the past 3 years. And which local HRT brand would you recommend?
Why is she on Depo-Provera? How old is she?
57. Yeah, good question. I mean, this is an anonymous attendee.
So first of all, she should be taken off Depo-Provera. Depo-Provera is going to potentiate her flushing. Depo-Provera should not be used in a postmenopausal woman at all. You know, if you're looking from a cost perspective in this patient, I mean, there are some patches that are available in the government sector, or you need to think about using an alternative. For instance, if it is a patient that requires transdermal and it's not available or is too expensive for them, then you can think of one of these other alternatives like an SSRI or an SSNRI in that patient. And certainly I would use a transdermal in her. A transdermal if she's got a uterus with utrogestin.
Okay, that's easy. Next one is a 48-year-old postmenopausal woman on Novem. What is Novem? It says here 1 milligram.
Novafem.
1 milligram estradiol, 1 milligram. Yeah, it's Novafem he means, or she means. Still complains of depression. No contraindications to HRT. Which would you recommend? But again, that's, what do you say, Trudy?
So if the person has depression, I mean, obviously depression is also, was the person depressed before? Are they on antidepressants? You know, I mean, what from a DSM classification, you know, not all depression is menopausal. But from this patient, I probably would move them either to a transdermal, utrogestin plus Vagifem, or they could use a transdermal patch with utrogestin. But, you know, also check what is the depression about. Are they well controlled? Do they need to see a psychiatrist or be put onto an antidepressant as well? But Novafem is sequential.
Okay, we better keep going, Steve. This is a good one from Douglas Woodstands. When initiating treatment for menopausal symptoms, what would make one choose tibolone over traditional hormonal therapy if the outcomes in tibolone are so comparable? In other words, why would you use tibolone and not utrogestan and Femigel?
So, I mean, initially tibolone was cost. I mean, even though there are generics, it's still quite a costly drug. And most medical aids won't cover it. So, I mean, I guess it depends on the patient's financial needs. Also, if you use the combination of Femigel and utrogestin, it also is quite pricey, as opposed to using Estralis or Evrelconti or one of those continuous transdermal hormones. So cost is one thing. And the other thing is breast tenderness. So women with big boobs and tender breasts, tibolone is your option.
Okay, thanks very much. So,
thanks.
Very good answer. So the side effect of tibolone, Steve says, Trudy, is poverty. Then there's one or two people that say, thank you for a wonderful meeting, Trudy. Some of them have to leave now for something else. Is there going to be a recording? And there's another one that asked the same question. Can we share our slides? We'll ever speak to Ash afterwards, and Ash will be able to organize that for her. Any other questions, Steve? You know, I don't think, Steve, have you actually finished your presentation, Trudy?
No, I can go through some alternatives that you can use. And I mean that.
I mean, I don't want to stay on, can stay on, because I think this is actually something that I'm also quite interested in.
There's a huge following you've built up, Trudy, so if you could whip through those, it would be wonderful.
So SSRIs, why they work is estrogen withdrawal decreases your serotonin. And they've shown efficacy in decreasing hot flushes. But what I want you to note is that its effect in the liver, on your CYP2D6 pathway, and its efficacy in tamoxifen patients is reduced. So you have to be careful of the type of SSRI you use, particularly in patients who are on tamoxifen. So you need to avoid, for instance, the paroxetine and fluoxetine drugs in women who are on tamoxifen, because it decreases the efficacy of tamoxifen. And nobody really knows that. And that's something that you need to take into cognizance if you're going to use these drugs. The other one is the SSNRI. So you can liberally use an SSNRI in somebody who is on tamoxifen. And what they've shown is there's no added benefit by using a higher dose than 150 milligrams. In fact, the dose where they found the maximum effect was on the 37,5 and the 75 versus 150 or even higher. So those are drugs like venlafaxine or Effexor is the trade name, or citralopam or Sirlift. And their effect has no effect on tamoxifen. So that's a better drug to use in a patient who has breast cancer and is flushing. Gabapentin and oxybutynin, who thought oxybutynin has some reduction in hot flushes? But you be careful of oxybutynin in old patients. So in elderly patients, it leads to cognitive decline. And that's why basically, from an overactive bladder syndrome, oxybutynin is not as good, for instance, as betmega, because betmega is an M3 specific inhibitor in those patients. And then I've actually done, I've had 3 patients that we've done a stellar ganglion block on who've had efficacy for their hot flushes. So this is something that you can consider, but we've got some really good intervention radiologists that I'm lucky to have contact with, and they've done the stellar ganglion block for me in those patients who are breast cancer survivors with severe hot flushes. And I think this was my final slide, that estrogen has a positive effect on bone, brain, hot flushes, and your cardiovascular with the window of opportunity. Always use a progestogen. Think about tibolone from its testosterone and libido effects. Transdermal is usually best. Transdermal progesterone cream is inadequate for endometrial protection. And that's that.
Yeah, so thanks everyone for staying on. I see most people are still here. Thanks to Chris as well for keeping the video going. And unfortunately, neither Trudy nor Pete are here. So I think they did indeed bring up a lot of important questions, and a lot of questions were fielded during that actual webinar. And as you can hear, it was held quite a while ago. So it was probably about 3 years ago. So, but I think a lot of things are still very relevant, and I think we got a really good update from Trudy. So in absentia, really want to thank her for a wonderful talk. We do have 4 questions here. Mauria's asked, why is the estrogen in your COC, the DVT risk factor, but in hormone therapy, it's the progesterone? Women on estrogen only hormone therapy have less risk factor of DVT than a combination hormone therapy. Maurice, I'm not a hormone expert, but I think with the COC, obviously much higher estrogen doses are used, and the COC has a very different type of estrogen. So I think that is why it's the estrogen there in that combination. And then obviously the progesterone bringing in the risk factor in the hormone therapies, I think it's got to do something with how the progesterone stimulates the liver and the clotting factors in the hormone therapy level. So I think that's actually where it all lies. We are running out of time, but just get to Frikkie Smith's question. What is your opinion regarding the breast cancer risk in women with repeat Mirena usage? And how many times can you replace a Mirena? So we all know that there's a very small risk of increase in breast cancer in women with a Mirena, but it's a very small risk. I think it was a big Danish study that looked at that. But the relative risk was about 1.2, so it wasn't very high. Didn't seem to have a cumulative effect, Frikkie. So I think it's something that you can maybe mention to your patients, but it's I think the risk is so small and it's quite negligible. I think it was like 1 in 7,000 or something like that. So it doesn't really increase it that much, and I don't think it really would make a difference to our the way we practice and the way we do our advise patients on the use of the Mirena. And then an anonymous attendee brought up the whole issue of homozygotic and heterozygotic factor 5 have significantly different risks for VTE. And it was really just commenting about the whether you should give Xarelto to these patients with the factor 5 Leiden. And if the patient is homozygotic on genetics, they should go on Xarelto. And then again, this anonymous attendee just saying that always a transdermal. remember there's heterozygotic factor V Leiden is a much lower risk of an embolus. It's like something like almost maybe 20 times less risk than the homozygotics. And then lastly, I don't know if Chris, you as a geneticist, have you got a comment?
Yeah, I was just about to say, I wonder, is it standard practice to screen for these heterozygotic or homozygotic conditions beforehand? Because that's such an easy way to know whether there is a risk or not, because we can screen for these things. Both of these are examples are SNPs, single nucleotide polymorphisms. So they're quite easy to screen for. Is that something people do? Do they screen for?
I think so, Chris. I mean, I think once someone has actually been diagnosed, I think they often do genetics on these, and also specifically families. Would be tested to check to see, if someone's got the risk, then or the genetic gene for it, then maybe someone else would again go that route as well. So I think they do. I don't manage a lot of these patients, to be honest. So maybe we can get some input from someone else on the call tonight.
That would be great, because I mean, what Trudy even mentioned on the video, there's a massive hereditary effect. So I think, because when does the diagnosis happen? It's usually after when, I wouldn't say when it's too late, but when someone has already been prescribed the wrong medication, then they find out, oh no. So it's worth doing this, at childhood or at, yeah.
All right, and then the last question, again from Moira: do obese women tend to require higher doses of transdermal hormone therapy for symptom relief and for the silent benefits? Moira, I don't know of any study or data that has actually suggested, or any evidence that suggests that they do require higher dosages. So I think we tend to really just stick to the clinical guidelines and clinical responses, like we do with the sort of patients with a normal BMI. So I don't think there's any reason to go for higher doses in these patients. And I personally haven't seen that they require higher dosages either. So that's all the questions for now. We have pretty much got to the end. I do want to thank all of you for joining us again tonight. We've got a great speaker next week. We've got Henny Boertz, who's going to be talking about an update on HPV. And these things do move a lot, they do change quickly. So I want to welcome you to join us next week. That'll be our last webinar for the year. And but please join us for that. I want to thank again Bayer for sponsoring tonight and for making tonight possible. And again, I just want to wish Pete in absentia a speedy recovery. And again, thanks again to Chris for making tonight possible too. So thanks all for joining. Looking forward to seeing you next week, and have a great evening. Thanks. Bye.
Fantastic. Thank you.